There we go. Now we're big. Hey, everyone. Jeff Horowitz with Dentists in the Know. Welcome to Humpday Happy Hour. This is your backstage pass for current trends, politics, and education in the dental world. It's live, and it's over your favorite cocktail or my favorite cocktail, whichever you prefer. I prefer my favorite cocktail, of course. Anyway, I am joined with two of my best friends in the industry, Dr. Jennifer Bell and Dr. Chad Duplantis, who actually decided that it was worth their while to join me tonight and maybe not make me do the whole show alone. So I am excited to have you guys back. For everyone out there, you may know what this is all about. We are all dentists, we are all business owners, and we are all educators. Our job is to bring all of you in the know. Tonight, we have an incredible guest who's going to talk about something really we haven't had the chance to talk about yet, which is geriatric dentistry, care for patients with, potentially dementia and Alzheimer's, and mobile dental care. So Dr. Joy Poskozim is going to be joining us tonight. I'm really excited to talk with her, but just as excited as I am to talk with her, I am that excited to talk with my two besties because you've been gone.
Hey,
have we?
Yeah.
You know what it's like when like one of your kids come home and cook in the kitchen, and then you go in there and like all of your shit's moved around?
Yeah,
That's what it's like when I came into the studio tonight. Like all of the little things were moved. There was a banner running across the bottom. The screen was all screwed up. Jeff, what did you do last week?
The banner was great. They loved.
We were gone for an hour.
What's that?
Yeah, we were gone for 1 hour,
dude.
Yeah.
1 hour.
Burn down the house.
I had the banner going. I had the people going. I had my multiple screens. I did the news. I'm just saying.
A one-man show.
One-man show. I got the banjo, the harmonica wrapped around my head. My foot's
I'm Dick Van Dyke and Mary Poppins.
Yeah.
Hey, by the way, I think there's a great song that's pretty recent out called One Man Band. That's what you were, Jeff. You were a one-man band.
I was alone.
Well, we
down
go
in the shallows.
You were down in the shallows.
Well, for those who don't know, we've all been apart for almost 2 weeks because
that's right.
Jeff was in Europe, and then Chad and I just quit for a week and then came back. And so, between all of it, we've been missing each other, I think, a little bit.
Yeah, it's been a rough couple of weeks. So, hey, Jeff, you want to give us a quick recap on IDS?
So I have all of these interviews we've got to get out there. I keep trying to upload them to the Google Drive so that we can edit them a little bit for time, because some of them got a little lengthy. Some of them I think we can get to under 2 minutes to put out as an Insta reel. I mean, I got so many cool interviews, but the overarching experience was just, it's so cool to be there and see stuff that we're not even going to be able to think about here for 4 or 5 years. And, I talked a little bit about it last week, but the technology and seeing what's coming down the pike really enables you to prepare for the future and say, okay, I better get my ducks in a row with 3D printing, right? This is everything in the future. I mean, it is everything from what we do on our side to what the lab does to anatomical models that will help us simulate surgeries before we actually do them. There is just, you go to these meetings and you see the future of dentistry in front of your eyes. And even though it's not happening in the United States for a year or 2 or 3 or maybe even 4, you're preparing for it. And it's invigorating. It really is. I talked with a lot of cool innovators and saw some great technologies, but you guys will be there with me next time.
Do you think it's
I've already
equally as
got it on the calendar,
frustrating?
Jeff. I just want to let you know.
Yeah. Do you
Yeah.
think it's equally as frustrating? You go and see this stuff and you're like, either I wish I had it now, or you also know the US will be one of the last places that it will get approved in, and then we'll actually get access to it?
So, that's a great question, and it's a double-edged sword. So, yes, you're frustrated because you can't get it, but there's also some solace in knowing that some of the kinks are going to get worked out before it
Facts.
gets to
Yeah.
America.
Yeah, yeah, yeah.
So, there's two sides to that, and especially in the digital world, it's understanding as my experience and my education grows on the digital side, I'm realizing how many places it can break down. And that's the piece that nobody's really talking about, is that there's all these potential places for breakdown. For example, today I had a sleep appliance that came in that I made for, it was an upper denture that was implant retained. So denture comes out, the upper piece to the sleep appliance snaps over the locator
Oh,
attachments.
cool.
Right.
Yeah.
And then lower traditional. But anyway, it was kind of a mix and match of digital and analog. It had to
Mhm.
be for what we were doing. And yet, somewhere along the line, my analog bite got thrown away and it went to a digital mismatch, I would say, of the two arches. And like literally, there ended up with maybe a 30-degree cant. That was just, I've never seen anything like it. It never would have happened in an all analog situation. It probably would not have happened in an all digital situation, but it's that in
Yeah.
between, it's that gray zone. So there's just a lot of procedural stuff that we really need to get down and get on the same page with our labs on.
Well, and if I can just kind of intervene, while you were in Cologne, I was also serving on the Align GP ad board. And it's the same thing where companies in general, let's take a large digital company like Align, hyper focused on their platform and all the tentacles that are within their platform. But when I mentioned that on any given day, I'm interfacing with 12 to 20 different platforms, dashboards, tech support companies, trying to get everything to communicate together, some hybrid of analog and digital, all trying to make it work for patients, they were blown away. Not to their own ignorance, but when you operate in a microcosm of like, we
Right.
operate in the Align platform, it's so great and powerful, and it does phenomenal things. But when you put it on the ground and you look at how dentists operate on a daily basis, you're interacting with, if you've ever quantified it, I would encourage anybody listening to the show, go back to your office tomorrow and realize how many things you have to log into, how many things your staff has to log into just to start your day. And then how many things you have to log into throughout the day to keep it going. It's somewhere in the ballpark of 12 to 20 on average in any office. And that's the back end stuff you don't even think about. We brought up dental exchange. We were chatting about that earlier last week. That's a whole separate system just to file your claims to an insurance company. That's another dashboard. You, as a dentist, may not interact with it, but your team is. So it's
That's right.
all of these different platforms not talking to each other, operating independently, doing like 20% the same stuff. Anyway, it will be interesting to see how all of it sort of, I think, evolves into a few like big players that probably dominate 90% of that space in the next 10 to 15 years. We'll see.
Yeah, I couldn't agree with you more, and especially in the realm of articulation. Now there's so many different,
Oh, yeah.
yeah, there's so many different models as to how to bring function into your cases digitally, and there are a lot of good platforms, but again, it's that integration of which one do you
Yeah.
use, how well does it work with the CAD software that you're using now? How well does your laboratory understand it when they're making your restorations? Are you both wanting to work with the same functional software?
Yeah.
And
Yeah.
so it's really it's the Wild West right now. And
Yeah. Well, you make me chuckle because I have like 3 bite cases right now that are like,
yeah.
you know, like we just cannot lock it in. So yesterday, I was doing some different mechanisms to try to do tracings to figure out where the hell this interference was. Like, where is it? And he goes, "Do you see anything? Can you see anything?" And I'm like, "It is literally blue from the front all the way to the back, flat." Like, how does one know which one of the 3,700 movements that you just did is the one my handpiece should go to? No idea. No idea. He goes, "Can you see anything?" I'm like, "I see a lot of things."
Yeah.
But I don't know which one to do.
And when that's the case, put the handpiece away, please.
You have to. You have to. He goes, "Can you just fix it?" And I was like, "I don't know."
Yeah. No. Here, let me
I
just
just
cut
want to
part of
become
this
like
toe
a
off.
tiny, I want to become like a tiny cell and go on the inside so I can actually just watch what the heck is going on in there when they chew.
Yeah. It's pretty cool. Some of the jaw tracking softwares out there are pretty
Yeah.
darn good now. And there's a bunch
Dynamic
of
bite, I think, is going to be a big piece of
I'm sorry.
dynamic bite. I think is going to be a big piece
Oh
of
gosh, yeah, for sure.
where we go from here.
But and there's a ton
Is
of them
Chad
out
here?
there.
I think so. I'm just kind of sitting here listening. I was letting
Yeah.
y'all carry
Yeah.
on amongst
The
yourselves.
adults were talking. It's
Oh,
fine.
hi. I didn't see you there.
Hey, yo, that was. Yep, I'm with you.
Was it good? Did you get popcorn?
I was about to. I was
Yeah.
about to actually go get some Jiffy
Leave.
Pop and put it on the stove. And
So,
yeah.
so what's going on in occlusal composite world?
Yeah, exactly. Mhm.
I'm just
Hey, I believe we
teasing.
probably have news to get to. Would
Yeah.
you
Do
think we
we?
have news to get to? Yeah.
Doing.
Yeah.
Sure.
So
It's always a busy week now.
let's let JB do the news.
Let's let her do it.
All right. Well, I'm going to piggyback on a little bit of Jeff last week because he definitely hit a high point, and it is definitely getting a lot of attraction in most of the social platforms as well. So let's dive in a little bit more on some of these cuts that are coming as our new administration is sort of getting into the trenches a bit and trying to figure out their infrastructure and how they want to lay things out. Jeff was phenomenal last week talking about a lot of the downsizing that's going to come, particularly for the U.S. Department of Health and Human Services and what that may mean as future impacts for us in particular, but medicine and general health for American population. On April 1, they also eliminated the oral health division of the Center for Disease Control and Prevention. Now, no idea where that's going to go. That could just be part of a restructuring program where they put it somewhere else or have oral health as a subset of a different area of investigation and evaluation. So it's still a little too early to say, hair's on fire, sky is falling, all of those types of things as to whether or not this administration and the new Secretary of Health and Human Services will value oral health as we move forward into the next 4 years. But it has officially been announced that the oral health division will be eliminated from the CDC. So we'll continue to see how that plays out. Another follow-up to a story that we brought to you because we are always on top of things. Just a few months ago, we were hopefully one of the first to let you know that Utah was one of the first states to start to look at banning fluoride in their water source. Well, that vote is now official. They have officially voted to move forward with removing fluoride from their municipal water supplies. How long or how slow of a process that will be, I'm not 100% sure yet. We'll continue to watch that move forward. I do think that there is continued momentum from the federal level as well to take that down to the states to allow them to make that decision. and to no longer recommend fluoride in the water supply for American citizens. We'll see how that continues to move forward, but we do now at least have the first state on record that will be removing it from their water supply. Another hot, contentious topic for the week. We've talked a lot about access to care. We've talked a lot about staffing shortages, and many states have come up with different solutions to try to deal with hygiene shortage, assistant shortage, doctor shortage, etc. So Arizona is now coming online as one of the latest to offer a new alternative called the oral preventive assistant. They will be allowed to do scaling within the assistant designation outside of dental hygiene. These are expanded function dentists who will provide dental care services to patients under direct supervision of a dentist now or a dental hygienist. So that's kind of an interesting concept, right? They can include removing plaque, calculus stain with scalers, ultrasonic devices. They have to have already seen a dentist or a dental hygienist for their initial evaluation and diagnosis. So they have to already be in your recare system. They can practice a periodontally healthy patients. They're not going to be doing deep subgingival scaling or complex scaling root planing patients. They're not going to be doing that. But healthy prophy patients, stable perio maintenance patients could fall within the oral preventive assistant designation. So we'll see how this will go. They have to have 120 hours of didactic and clinical instruction with patients. So this just isn't like a stamp and now they can go forward with doing that. They have to go through a board-approved preventive assisting program to get this next tier licensure. Now, I'm going to play devil's advocate, maybe provide two different perspectives on this. Number one is a practicing dentist who can also concur with the challenges of finding staff for a myriad of positions that you may have available in your office. I like that Arizona is trying to come up with a solution. I like that they're trying to find a way to continue to help put patients under care, that we can at least try to deal with the access to care problem if doctors are unable to provide or fill empty positions within their office. What I also like about this program, and I'm sure this will be contentious and may get me a lot of hate mail, I love watching an opportunity for dental assistants to have upward mobility within their dental assisting paradigm without having to leave dental assisting altogether and going to hygiene school. I know I had a lot of phenomenal dental assistants that we sort of cap at a certain point of allowing them to do certain procedures because legally that's all they're allowed to do. Yet they are qualified and competent. And I would love to provide them that advancement in their career. And this could be the next step for them to have a higher income potential, but also just expand their function and be able to be more of service to their practice. So I do like that. I can totally appreciate it from a dental hygiene perspective. I feel the same way about dental health aid therapists and these mid-level providers as dental hygiene probably feels about these oral preventive assistants. Where is that fine line? How do we negotiate that? How do we ensure that they're taking the same high level of care of their patients that dental hygienists and dentists are taking of theirs? Don't know yet. The proof is in the pudding on how this will look in a few years. I can tell you that Alabama has been running a similar program for quite some time. This is not new in the world of dentistry. An incredibly successful program, actually, that is now becoming kind of a model program, I think, for a lot of states to look at. So just know it's an opportunity to at least have an open dialogue about how we're going to solve some of the staffing and access to care issues. The last thing on our docket to discuss today is that a dentist out of Kansas has filed an antitrust lawsuit. I just love these. You know, I see tons of news all day long about dentists doing dumb stuff. You can almost run a TMZ show all week long on dentists doing dumb stuff. And I don't like talking about dentists doing dumb stuff because I am self-aware enough to know that I could very much be the headline of a news story at some point and at some time. I like to focus in on dentists trying to make change. And this dentist out of Kansas has filed a lawsuit against Zealous Healthcare, United Health Group, including Elevance Health, Aetna, and Cigna. Dr. Dennis Ayer has filed this suit with an antitrust of conspiracy for controlling fees and trying to price fix against out-of-network payments to dental providers. I don't know what the outcome will be, but I love dentists that are trying to at least progress the profession forward and try to make it a fair playing field for us as business owners against the large insurance companies that have been lobbying against us for a very long time. So go get them, Dr. Ayers. And if we can be of support for your cause in any way, don't hesitate to reach out. And with that, that's the news.
Very interesting, to say the least. I
Yeah.
actually have something to add to it, but I want to get to our guest before it's too late. Hey, JB, can I see what you're drinking out of?
Yeah, my master's
Oh, really?
and my
Let me
master's
get
green
mine.
and my master's yellow.
Does yours say 25 too, Chad? Because I'll be pissed.
No, mine doesn't. Mine's just custom painted. There you
Yeah,
go. Uh-huh.
yeah.
Yeah. Hey, since I can't do two things at once, why don't I introduce our guest who's been patiently sitting in her
Yeah.
car since we started this. And then we can review the news after our guest this evening, because I have
Love
a
it.
couple of things that I want to add. So I'm going to introduce our wonderful guest, and Jeff, I will let you bring her up to the stage. But
Oh, wait.
I will start
mean,
and say,
you can't bring a guest on and introduce at the same time. I wonder how you would do with a whole show with two guests. Just
By
asking.
yourself.
By yourself.
I know that this is a family show, but I'm just saying, yeah, okay. Yeah, all right. So I'm just saying.
I'm just saying.
Anyhow, I met our guest a few weeks ago. We always talk about how dentists in the know is kind of the CE after the CE, but we had a great day at Glidewell Education, and we had some speaker training in the afternoon, and we were sitting around the bar afterwards with the speaker trainer, who was actually a phenomenal human being. And I sat next to another phenomenal human being, and that other phenomenal human being is with us tonight. It's Dr. Joy Poskozim. I think I said that correctly because I asked her how to say it, but it's a very complicated last name. She's a general dentist. She's a speaker. She teaches to both dental and medical audiences about what they need to know about providing mobile dental care to patients in the comfort of their home environments, which I think is something that's very important. She's a true advocate for the geriatric profession. She is the dental director for several nursing care facilities. She educates staff as well as provides care to the nursing home residents. She makes in-house calls in and around the Chicagoland area, and she has been in private practice for 25 years, practicing integrative health general dentistry at her office on the northwest side of Chicago. And she's been performing dental procedures on the homebound for over 16 years. And she's just a wonderful human being that does a lot for the geriatric population. She knows a lot about dementia and, memory disorders. And I'm just honored to have her here because I think it's a very important topic. But beyond that, she went to Marquette, NYU. So she went to a couple of, pretty crummy schools, but we'll forgive her for that. I'm teasing. You actually add you. I remove you. I saw you down there. I'm sorry. You're here.
That's all right. I'm back.
We're glad to have you. And you've got a lot of wonderful accolades, and you did go to two actually pretty incredible schools. So I'm a little jelly there.
Welcome, Joy.
Thank you.
Hey.
Thank you. So where do you want me to
go? Being here. So
absolutely, I appreciate it.
Yeah. So tell us a little bit about. We read a lot about your journey in dentistry, but how did you start, and how did you end up doing what you're doing right now? Was there a specific moment, or was there a need, or was it just kind of like I got thrown into it, or how did it go?
So my grandma needed a new lower partial denture. Horrible sciatica going down her right leg. She, lucid, but pretty much dead weight. And I got cornered Thanksgiving, the first year I'm back from working in New York. And from my two aunts or two daughters saying, look at grandma, she's having insure at Thanksgiving. Our dentist won't come to see her. It's really difficult to move her around. can you please come see her and make a denture? And so I did a little research, and it turns out in Illinois, I can practice on Illinois soil. Woohoo! So yes, I'm able to do it. So I go make her a lower denture. And as the story goes, it had to be done by this one particular Sunday, because the one place that my aunts would take her to would be church. Very important. So my dental assistant let me have her Dremel. We sterilized some drill bits. We adjusted it. I adjusted it for her. And I get a frantic phone call after this one particular Sunday, after I delivered it, where from my Aunt Joan saying, Joy, we must have given your business card out to 6 different families. We took her to her Senior Ladies Guild luncheon, and she announced to the entire crowd that I make house calls. This was an I love you, Grandma. This was a Merry Christmas, Happy Birthday, Happy Grandparents' Day. You get the idea. But suffice to say,
I'm going back to my office on Monday. Yeah.
Yeah. I'm like, what? Wow. So yeah, literally, yes. I'm going back to my office on Monday. All 6 of the families called that Monday. And the one that did call the first was the granddaughter of one of the founding members of the Senior Ladies Guild. And her grandmother has suffered a stroke 2 years prior. And nonverbal, paraplegic, she can blink. She's got a G-tube. Now, the hospital, the hospital's like, look, she can no longer eat or drink from her mouth, but keep her mouth clean. Continue to brush her teeth every day. Awesome. Go hospital, right? So, but now it's been 2 years, and they can't understand why there is bad breath coming from her mouth, because everyone's been taking a part of this. Everyone's been doing this. What's going on, right? So I don't know what to bring. I don't know what to charge, but from the same parish, 10 minutes from my practice, on my way home, what the hell, right? Let's do this. So I go there, and imagine this beautifully coiffed, full makeup, nails, the whole 9. She looks amazing. Not for my sake. This is Nona. This is Grandma. This is the matriarch of the family. And this is how she wanted to be at all times, right? She's in her hospital bed. I've got the granddaughter that called at the 3 o'clock position, the granddaughter or the daughter right next to her. And I got the rest of the Italian family surrounding the bed, because once again, she's the matriarch, and every single one of these people have been taking care of Grandma, right? So what do we do when we do an oral exam or a dental exam? I introduce myself. We lift up the upper lip, right? She can't do it herself. I do it. Guess what I found? I found an upper complete denture. And then I drop the lower lip, and I find a lower complete denture. This woman is completely edentulous. I swear to you, the rest of the family leave, because you can imagine the order. Not to gross anybody out, but we're all dentists. Hey,
we've been there.
So, I'm trying to desperately remember the prescription for Nystatin. I was so proud of myself internally that I remembered the term Nystatin. Yeah, because you can imagine the thrush. And then they don't have any denture anything. And so I'm like, do you have hydrogen peroxide? How about alcohol? I don't think so. Alcohol, not such a great idea. I like to drink it, not for the acrylic. Let's find some hydrogen peroxide. One person goes rushing out to a local, drugstore to get the. Anyway, I'm sitting there thinking, okay, how is this possible? And what I came up with was, after discussing it with the literally crying daughter and granddaughter, was that the home healthcare agency, when they were looking at her, when they were examining her and acquiring her as one of their patients, when they asked about the mouth, they didn't look in the mouth themselves. They asked the daughter and the granddaughter. And as far as they were concerned, this was her smile. These were her teeth. And I think what happened was this. She probably went to her dentist with a picture of herself when she was younger and made an exact replica, because these were not chiplets, right? I mean, tooth number 8 was a little askew. There was a little bit of a crossbite. You know what I mean? I mean, they were very well-made dentures, but this is what she wanted to show. And, she's a widow, so obviously her husband took the secret to his grave, and no one else knew. So if I can say anything about this, is that know what's in your loved one's mouths, because the home healthcare agencies, it's not that they don't care, it's that they don't know what they don't know. They are not trained to look in the mouths. I go to 18 different homes. I have another story where a woman, granted, 100 years old, God bless, but also incredibly lucid. She gets admitted into a very ritzy home on the north side of Chicago, in the North Shore, if you will. And the daughter, and who hasn't seen her in 20 years, you know, for care because she's been in Florida, the only daughter brings her mom back up to Illinois to have her be with her because now the husband has passed. And the admitting nurse who vetted me to come work there is literally asking all the medical questions, not to the very lucid patient. Can we say ageism a little much? But, you know, so she's now asking the daughter, who knows nothing about her care, what's in her mouth. She goes, "Ma, open your mouth." So she's like, this is the patient telling me this, telling me the entire story. She's sitting like this, her arms across in front of her, and she's like, "I didn't know what to do." I smiled at her. She's like, "Oh yeah, those are her natural teeth." Guess what I found? Complete upper denture, lower all on four fixed. Once again, completely edentulous. And so the nurse, you know, the care plan, that it just really disturbs me because the care plan is based on how someone can eat, which means it's based on not just dysphagia, but it's also based, as we all know, but they don't know, on how many teeth they have. How are they able to chew? What are they chewing on? Right? And so because she's not, first of all, she's 100. Number two, she's got rheumatoid and osteoarthritis. It's very difficult for her to remove her upper denture. So she's like, and this is how she literally said it to me, hands crossed. Well, she's like, "Well, if they don't care, why should I?" And she didn't say a word. That upper denture had not been out of her mouth for 3 years. So suffice to say, I mean, once again, Nystatin galore, you know. And another problem, though, that I will say is that I will see some of these residents after Nystatin has already been prescribed by the physician. Fantastic. They don't prescribe it for long enough. They will prescribe it for about 5 to 7 days. Sometimes I've seen it for 3 days. And they expect this to be all cleared up. And then they call me because the Nystatin didn't work. Well, that's baloney. It will work if you prescribe it for the appropriate amount of time, which is 10 days. So I will re-prescribe, and now I'm going to find a substitute, which there are fortunately several that Medicare will pay for, but I will then have to prescribe it for the appropriate amount of time. And it explained to the nurse that, yes, doctor did prescribe the right thing. It just wasn't for the appropriate amount of time. So that's a problem as well. And if I can share anything with the audience, is that one of my key goals in educating is we as dentists can be the bridge for when our patients become their residents. When our patients become their residents, it's not like they've fallen into a black hole. Engage with the nursing home. Number one, you're going to look like a hero to the family. But number two, you're going to be providing them with information they are not able to get for themselves because they don't know what to look for. So if you know that someone is going to, you know, nursing home A, reach out to the executive director, find out who that is. Have your you don't even have to do it. Have your front desk do it. Have somebody, you know, do it in your office. And then provide them, or with the director of nursing or with the assistant director of nursing, the information that you have on said patient. So there could be proper continuity of care. You don't have to go to the nursing home to see this person. That being said, if they will know what you know about what's in their mouths, that continuity of care is now going to be done. Number one. Number two, a better, more accurate care plan can be provided for this patient. Meaning, if the person has partial dentures, if the person has complete dentures, then, and if they need to be taken out at night, that needs to be explained. Well, maybe they shouldn't be living in independent living. Maybe they should be living in assisted living where assistance can be provided for said patient. Oh, this patient has been seen once every 3 months in my office for a cleaning. Do you have a dentist or a dental hygienist that comes to your nursing home? And if not, Special Care Dentistry Association, you can log on and you can find a dentist in your state, in your ideally county. Special Care Dentistry Association, you can help provide you with that information. You can do that for them. It takes 30 seconds. But once again, the more information you provide to these nurses who, once again, don't know what to look for, then you will look like a hero to the family And I can't tell you how many patients I have gotten from the nursing homes, because I have seen the family members as well as nurses, CNAs, certified nursing assistants, because of the continuity of care I've provided to them. So I'm not asking anyone to do what I do. It's backbreaking work. There's a reason why I'm in my car. It's because I didn't get done today until Central Standard Time, 7 o'clock. I raced to my car to be here. So important for me to be here to explain this information, because if we don't do this for our patients, then it's not going to get done. We can't assume that it's going to be done in any home, let alone a really awesome, X amount of dollars per month that they're paying for. And I can't express that enough. And then also too, when it comes to dementia, there's, we as dentists can no longer say, oh, I'm so sorry that your mom is suffering from dementia. We know too much now. They know too much now. The medical field knows too much now. We have to say, I am so sorry that your mom is living with, not suffering, living with Alzheimer's. I am so sad, or I feel so bad that your father is now living with Lewy body's dementia. The tests are out there. Like for example, Bruce Willis, he has frontotemporal dementia, right? A scan did that to show that he has neurodegeneration in his frontal and temporal lobes. We have, as dentists, we have to be specific on the types of dementia that our patients are now going to be having an earlier and earlier diagnosis for, as well as coming into the office to be seen. And we need to know the different kinds. So there you go. There's my spiel.
Okay.
I love it.
That was great.
I want to back up, and I'm going to micromanage for a second, because
go for it.
First of all, first thing that I noticed, which I love, you're extremely passionate about what you do. And I think that's absolutely amazing. And there needs to be more of you in the world. But let's back up just a little bit, because I think you hit the nail right on the head when you said something about Nystatin. And yes, I've prescribed it on several occasions. But let's back up to that just for a second. 10 days is the therapeutic dose of Nystatin.
Yes.
Okay. So let's say you find somebody, this may be a dumb question, but I guess it really depends when you find out how long it was prescribed for. If they prescribed it for 7 days, do you prescribe them 3 additional days, or is it how long it's been since they've been off of it, or if they're still on it, that you prescribe them a whole another 10 days? Because it's my understanding that you can't really, I imagine you wouldn't want to be on it forever, but you can't really overdose on Nystatin. So that's question number 1. So I'll let you break that down.
So to answer that question, excellent question. It depends on how bad it is. So if this person, if it's under proper care, the person should not be wearing the denture while they're dealing with thrush, right? Right. However, a lot of pulmonologists now are recommending that their patients wear their dentures overnight to keep a better patent airway. So our dentures have to be made better, as one pulmonologist from the University of Chicago told me. So if the patient is being told to be wearing their denture, regardless if they're being treated with thrush, I'm going to prescribe another 10 days, and I'm going to prescribe an alternative to Nystatin, and there's several out there. That being said, if it's someone that hasn't been wearing their denture, they're beginning to clear up, they still have signs of it, I can still scrape some of it off, but it's not nearly as bad from what the CNA, and it's usually the CNA, the certified nursing assistant, not the nurse, who can tell the difference, because they're the ones that are treating them all the time, then I will then prescribe an additional 3 days. Okay. Sometimes maybe 4, just to be on the safe side, especially if they've been off of it for less than a week. If they've been off of it for more than a week, I'm starting all over again. And so I'm going to start with a Nystatin for 10 days. So if I'm being told about this and they've already stopped their regimen, I'm looking at this as a brand new case. And so depending on how bad it is, if I think that it's getting better, then I will prescribe the Nystatin again. If I don't feel that it's not as good as it should be, then I'm going to prescribe its alternative for the appropriate 10 days.
Just so we can be clear with our listeners, and I'm sorry to interrupt, I just want to make sure that everyone is on the same page, because there is systemic Nystatin that can be given, there is ointment, there is cream. And so what combination, are you using a combination? Are you putting any kind of a Nystatin ointment in the denture if if the physician says, hey, we need them to wear their dentures for the airway, which I absolutely get. What are your protocols there?
Excellent question again. So yes, if they are being required to wear their dentures, or the patient refuses to not be without their denture, because we have that too, right? I mean, there's a social level on this as well. They want to be able to be interactive with you. They want to be able to sit at the dinner table with their colleagues, with other individuals. So yes, I will definitely do the cream as well as the systemic. I'm always prescribing systemic, period. Always. Great question. However, I also have to make sure that the CNAs, because it's the CNAs that are doing this, not the nurses, know how to apply it. And so then I am then explaining how to apply it. And it really becomes a problem if these people aren't lucid. So if we're in memory care, which is where those that are living with one of the dementias are, then we have to be, the biggest fear that the caregivers have, whether they're certified or not, is the fear of getting bit. Right? Their fear of, even if they're a dentulous, there's the fear of the jaws coming together and now their hand's going to get stuck. And this is a real fear for them, especially if it's happened to them in the past. We have this problem potentially with someone with ALS. We have this problem with any one of the dementias, especially if they're in mid to late stage. And yet, we have this problem. So then I am in there, tell, show, do, right? Going back to tell, show, do, I am telling them what I'm doing. I'm not asking, because if I ask, of course, what is their answer going to be? No. So it's going to be tell, show, do. I'm telling them what I'm doing. I'm showing them what I'm going to be doing. And then I do it. And I do it for the caregivers. I apply it for them so they can see what I do. And then maybe I'll only do like one half of the mouth, like the right side. And then I have, ideally I'm doing this where there's a shift change. So there's two shifts being there at the same time. So I have one of the caregivers do the other side. And I'm standing there watching them do this because they literally don't know how to do this. So I'm showing them how to do it, and then they are doing it themselves. And then, then there you go. And then of course I'm writing a POS, or a physician's order. I am a physician. We are physicians. We are oral physicians. I am writing a POS, a physician's order sheet, to say that this has to be applied X amount of times for how many days. And there you go. So great question. And yes, for those that are living, or they're required to have their denture in, or the patient doesn't want to be without their denture, then this is what I'm doing. Other than that, if the denture can be kept out of the mouth, I'm just doing systemic, because once again, I can't confirm that on a daily basis, 2 to 3 times a day, the cream is going to be applied appropriately, or applied at all.
I just see like a huge advantage to those little spongy sticks that they use in the elderly in the hospital with Nystatin.
Yeah.
I'm like,
actually, I now want to invent a mouthwash of Nystatin for denture soak. Yeah. Just for
that would be awesome. Right? I would be your first buyer.
Just soak them in there.
JD.
Yeah, that'd be fabulous.
Oh shoot!
Well, I will say the cool thing is Glidewell is making, they're the first ones on the market, and I'm sure it's going to follow, to actually be making antimicrobial acrylic. It's been patented. It's been approved by the FDA, and therefore, so I don't know about any other lab. There may be, but as far as I know, is right now Glidewell is making an antimicrobial acrylic to help prevent Nystatin from even being formed in the first place, especially for those that wear their dentures 24/7. So,
and the studies I personally are pretty freaking fantastic, by the way.
Yeah, you can get all the colors, I mean, all the different shades of the gingiva. I mean, it's incredible. And they've tried this not only in which one is which? In vitro, but also in vivo as well. So they had, patients themselves come in that are being treated by the dentists that are actually employed by Glidewell to do the research. Quite impressive research that was done. And it's, right now it's the only kind of denture that I'll make, because obviously we want to do as much as we possibly can to prevent it from happening in the first place.
So focusing on edentulosum, we've talked about that, but let's talk about what other services on a mobile team are we doing crowns? Are we doing fillings? Are we doing oral hygiene? Are we doing scaling? Give me the gamut. Like, what's going on?
Woo! Oh yeah. So, okay. So I'll start with extractions. So with extractions, if they're on blood thinners, then I need a med clearance to make sure that the person is medically competent to have oral surgery, and as well as to know what the protocols are to be off their medication, even if it's Eliquis. So, and what I would love what's going on right now in the medical field is that it's not one standard protocol because everybody is different, right? And for someone that's on heparin, their INRs are going to be different. For someone who's on Eliquis, it's going to be different. Are they taking it once a day? Are they taking it twice a day? How long have they been on it? So I want that med clearance. The medical doctor has to be in Illinois. Different states, different rules, but in Illinois, it can't be the NP, it can't be the PA. It's got to be the prescribing physician to sign off on how many days it is, how long that one of the blood thinners has to be off, and then again when to be put back on. And I love the fact that it has varied from patient to patient because once again, everyone is different. So I'm loving that. Besides extractions, I do cleanings, I do exams, anything you could possibly think of at the denture. I've got an awesome lab that's localized that I can do a turnaround time within 24 hours. For bigger cases, I use Glidewell. And then I re-cement crowns. I will do a ton of SDF. And I'm a huge fan of them all. So I'm a huge fan of Elevate's gel, which can go in approximately. That sticks, it stays there. I love it. I love Riva's, Riva Aqua versus the Riva Star, which is ammonia based. This is water based. And so I can put it, especially if the patient has a high lip line, I can apply that material. I can apply the potassium iodide afterwards. Yeah, it's 3 steps, adding the fluoride on top of it afterwards. But I don't care if it can help reduce that brown stain. Mm-hmm. And Centrix has Silver Sense, also a water-based SDF that I adore, and it's also 1/3 of the price of Elevate. So, I love Elevate, but I'm just saying, Centrix is cheaper, and it does the same thing. And the fluoride I'm really liking right now is SDI's fluoride. And you're like, SDI? Yeah, SDI is making a fluoride. I think it came out at midwinter in Chicago, and I love it because it sticks. This is not something you're just going to put across the mouth. It really sticks. So I love it to be the 3rd step or the 4th step, depending which SDF you're using, because it stays put, and it's where I put it, that's where it is, and it covers up that SDS. And even if this person is going to be, not following the rules because they're in memory care or for whatever reason, I know that it's done its job. Historically, people were saying that with SDF, it has to be applied multiple times. I disagree with that. If I can get a spoon excavator in there and I can get down to tertiary dentin, then I can apply it once. I'm scrubbing in that SDF. I'm not just gently applying. I'm scrubbing that stuff in. And then and I do it 3 times, a little air dry, 3 times. And then I'm applying the fluoride, that SDI fluoride on top of it. And I know that stuff is going to work. It's going to last. And I'll go back the next month. Usually I go into my homes once a month. I'll reeval. And I would say probably 90% of the time anymore, it's a one-shot deal. So this is what's really helping us mobile dentists. And to be honest with you, I'm a house call dentist. And the difference is this: a mobile dentist is someone with a van. You do not want me driving a van. It's hard enough for me to drive this SUV, and it's a little guy. So I'm never going to be driving a Winnebago, suffice to say. That being said, I'm a house call dentist. So I will park, and I'm going into their home. So for those that literally cannot leave their place, leave their facility, most of them for memory care reasons, I'm actually walking into their unit. I'm walking into their apartment. I'm now a guest in their house, and I am treating them there. But yeah, so SDF has saved so many teeth. Mm-hmm. It has really helped prevent a lot of, caries going bad, where now the tooth has to be extracted because I'm not doing root canals. But I will re-cement crowns back on. When it comes to actual fillings, if a filling has come out, I'll take an impression and do an inlay if I know that this tooth is okay. And I have the Nomad, I have Dexis. And for those that I can take, I have the little pitot sensors, because a lot of them, they don't like the regular sensors. Yeah. I use pitot sensors on them because they're also smaller and than us. They're older than us. Height is dominant, right? Tall is dominant. So we're getting taller as as our generations increase. So I'm using a pitot sensor. I make sure there's no internal decay. Is that really true? Yeah.
That's unfortunate for Jeff. The camera makes him look a lot taller.
Yeah, sorry to tell you, but that is what it is.
It doesn't happen.
Hey, wait a second.
What?
Team chat. Hold on. Joy, you're out for a second. Hey, we've never done this before, but I'm going to tell you right now. This is our first webinar. We're doing a webinar on SDF. You think she'll agree to it?
Yeah. I like it.
Okay, sorry, you're back.
Okay.
Yeah,
Business
you just got
idea.
nominated to do a webinar on SDF for the elderly.
Woohoo! But I got it.
Second
Okay, but
one.
we got to be specific about SDF. So SDF has been approved for children as well. In fact, when it first came across the pond to the US, it was specifically only for children. Now, I have been told by several pedodontists that it's only meant to be a temporary solution for children until they find a dental home or until treatment can be provided for them. But for our seniors, it can be considered a permanent solution. So that's where I just want to let you guys know. So if anyone gets upset about this, I wanted to be specific about that. But yeah, bring it. I would love to
Okay,
talk more
well,
about
I could
SDF.
argue
No,
that
I just think it's so
primary
needed, and
teeth are
it's
temporary.
do what, JB? I'm sorry, I cut you.
You
I
can
hear it.
argue primary teeth are temporary. I mean, like,
Yeah, that's
Yeah.
what I was
True that.
thinking.
True that. Hey, you're preaching to the choir here, but I'm just telling you what the
I know.
pedodontists are telling me. All right.
Yeah, but no, I
Heard.
appreciate that, and I think we all appreciate your cognizance of the profession. But the
That's
thing
all right.
is that SDF kind of had its. I say it had its heyday. I mean, it was like the answer to
No,
everything.
we're
I've
still
got an
using
arterial
it.
bleed. Well, put some SDF on it, you know. And that was the answer a few years ago, and it's kind of died down, thankfully. But I still think that the vast majority of us, including myself, don't have any idea how the hell to use it, you know? And it's
fair.
something that we're kind of fearful of because we hear from other people, oh, it stains, oh, it does this, oh, it does that, you know, and it's like you get all this misdirection from dentists and from other people that I think it would be a very powerful topic
Yeah,
of
I agree.
conversation. And
I
And-
think it'd be
and-
great.
I love it. And I can,
I
you know,
also-
and we could talk about the ways that I'm using it in my office for the patients that are coming to me.
Well,
So that's
and
a
the
discussion for that
differences-
time.
And you talked about Revastar and like the differences of the different materials that are out there that are like SDF versus what happened to Joy again?
I hit it with my
SDF.
thumb.
What?
I was
You don't like
so
me or
excited.
something?
I hit it-
Chad,
I hit
knock
my
it
little mouse
off.
pad and I removed her. I was like, get the hell
Knock
out of
it
here, Joy.
off.
Sorry.
Whatever.
I'll go
No more bumps
back to
before
my
the show, Chad.
concept.
You're on edge.
Yeah. All I was going to say was there's a lot of SDF alternatives that can work, but you have to know the protocol. And so I think you really could go pretty far into that discussion. To your point, trying to eliminate the stain, like the benefits of the product, but
Well, yeah, and I can show you X-rays of one of my presentations on someone that's got Parkinson's could come to my office, but I'm like, you know, there's issues with this. I'm going to use SDF on this, and I'm going to save these teeth because the gum levels are pretty good. So,
Right.
you know, bring
Right.
it. I can show you a really good scenario of someone who we can definitely use it on, save these teeth, not go crazy trying to do a subgingival filling, you know, kind of class 5. We throw this in there, and okay, let me think. We're 5 years out, and those teeth are there. They're stable,
Yeah.
hard tooth structure. It's awesome.
yeah.
So
Yeah.
bring it.
All right, we did get a question from a viewer about Curodont as well, which kind of falls in the same preventative bucket. I don't know if you've used the product. It sounds like it's similar to one of the other ones you mentioned.
I'm not familiar with Curodont, so I'm very curious about that. I just
Okay.
been stumped. I don't like being stumped, so I'm going to have to do a ton of
Damn
research
it,
on this now.
Partha?
Hey, you know what? It's Partha. He brings up obscure shit all the time. We just look
Yeah.
at me. Yeah.
Is it available in the U.S.? I'm just saying.
It is.
Yes.
It is.
I'm
who
not
makes it?
familiar with it either, Joy. So I'm with you.
Vardis. That's right. It's marketed to go in between the teeth as a fluoride treatment. So it's an argument that you can make for it. And I've actually researched the product a fair amount, trying to decide if this is a good adjunct therapy for us. Because SDF, the one argument consistently has been direct application. You have to be able to get to the lesion to be able to treat the
Yes.
lesion. And
True that.
Curodont is trying to change that paradigm on incipient lesions to say, okay, we're going to provide you an option. It's a floss technique, loaded up to go in between the spaces. With pediatric patients currently, and the pediodontist can now send me all their hate mail, I'll do a
Right.
spacer, I'll place a spacer, and then 24 hours later, I can come in with a very thin microbrush and do direct application to an incipient lesion. And it does work. To
Cool.
your point, it's a very effective procedure. But again, direct application. You can't do that for adults. And so I
No.
think dentists are just trying to find, you know, outside of the geriatric spectrum, like preventative, if you see an incipient, you don't want to open up, but all you're doing is flagging it, knowing 2, 3, 4, 5 years later, you're going to prep that tooth. You're just hedging your bet on when you're going to pick up the handpiece.
And when I'm seeing these patients, it's because, doc, I found a black spot on a tooth. Like this is already true blue, full blown decay. So I think it's going to be pretty rare where I'm going to be using it with my population of patients 100%. When I go out to the homes. But it sounds amazing. And hey, now I'm going to have to spend 3 hours on it.
Yeah. Okay. Curodont deep dive. Here we go.
Yeah, exactly.
I had one other question.
Go for it.
I love what you're doing, and I see a huge need in our community. I live in an area where a lot of folks are retiring here, and then we're kind of watching them go through that particular evolution as well, where they end up in different assisted living facilities, et cetera. And I think some dentists will be called to be the mobile doc to go in and be available. Some dentists will be that home care doc coming in, doing evaluation. How do they work together with the dentist in the field? And you identify something, do you ever send them to a dentist in their community for treatment? Because they're at least ambulatory enough or mobile enough that we can get them the care that they need outside.
Absolutely. Go ahead.
How do we all play together in the same sandbox?
Exactly. Oh my gosh. I never, ever, never want to take over anybody. If there is someone that is in assisted living and they have a dentist, but they wanted to be, in the comfort of their own home just to get an eval on something they might have seen, or their daughter or son might have seen, fantastic, not a problem. But yes, so a lot of the homes will have a shuttle service to be able to bring them to said dentist, and then I will coordinate that with them. If there is a situation where, they have, had a denture made by somebody else, right, and it was within a certain amount of time, and, that dentist is still around and is, local, then yes, I definitely want to have a conversation about that, that denture. Do you still have the study models? Do you still, how do you feel is the best to work with this? I will say, though, 9 times out of 10, the dentist is either, they haven't seen a dentist in a long time. They have now moved into this facility based from either, for us, once again, Chicago, from Florida, from, Arizona, from California, and their dentists are now, multi-states away. So, or, I'm like, well, do you want to see your loved one's dentist? And they're like, well, you come here. So what can you do for me here?
Yeah.
But yes, I will then be asking for, if I feel that I can't take x-rays, I'm going to be, doing a double down and saying, well, I need x-rays. If I can't take x-rays on them, then I'm going to be trying to find who this dentist was to see at least what has been in their mouth. Was, this tooth that the crown came off on, has this tooth been root canaled, right? Is this something that I can, I can put SDF on and then re-cement back on and feel pretty confident, considering this person is 95 years old and is in end stage, Lewy bodies dementia, that they could be taken care of. But yes, I always want to coordinate with the dentist that has been treating them, because there is something to be said about that, right? They know their mouths way better than I do. And so if there is someone that is in the area that they've already seen, my recommendation will be, if they can still go see their dentist, go see your dentist.
Absolutely.
And then I will provide with my information on what I've seen, what my findings are, and the reason why I feel it's important that this patient is seen. But I also might give some extra tidbits. Hey, by the way, that Sally is in memory care right now because she's in early to mid-stage dementia, and might be a good idea. May I make a suggestion to see her sometime between the times of 10 a.m. and 2 p.m. Of course, any dentist is going to say, woohoo, middle of the day. That's awesome. But you really want to see them at that time, because that's when they're most lucid. And you also want to make sure too, if this person, I'm a little concerned about, getting them out of their comfort zone that they've been living in, let's say for the last 8 months, maybe they're going to need some Xanax. Maybe they're going to need something to help with their behavior control. And I hate to use that terminology, but that's the terminology that's used in order to make sure this patient can be seen in a dental chair. So I'm going to give I'll give the caveat, like, look, I really think, this person can be seen by you. I think for the most part, this will work out really well. That being said, I just want to give you a heads up on how, what stage this person is now, and help me, I'll help you by suggesting these things. You may want to talk to their prescribing first, care physician or something like that to be able to provide the best care for them.
Joy, I'm going to butt in here because we are actually over time. That may have been one of the fastest shows that I can recall in a long time, and it's because I'm sitting here sucking it up as you're talking. I know probably everyone out there is really taking all of this in, and I literally have 10 questions that I could sit here and ask you right now. So what I'd like to propose, number one, is we absolutely need to have you back. Number two, I love Chad's idea of us doing a program on SDF and other techniques for particularly the elderly. I just have so many questions about what you just touched on, tips and tricks for, working with this population. My grandmother went through it. I treated my grandmother. I've had a lot of patients come through, and, what works for one doesn't always work for the next. So there's just so many questions that are out there that I hope you'll come back and answer for us. But I hate
as long as I don't get bumped off again several times, it would be more. I'd be more than honored to.
It's funny.
Did she say something? Hey,
now you're definitely in the club. He's treating you like he treats us.
Here's the promise that I'll make to you, and I've never made this before. I am going to contact you tomorrow and set up a second show if you would be willing to do so.
I think so. I'd love to. And maybe this time I don't have to be in my car. You can actually,
But here's the deal. Okay, so when I met you, I don't even think I knew that you did the mobile stuff. I was so enamored with the dementia, and that's what we really talked about that evening. And I love that we did this tonight, but this was to me, this was like a treat. I also want to thank you because you saved my job. Whenever I get guests, sometimes they're not that great, but like JB and Jeff are like, hey, you can bring her back again. And I'm like, this is fantastic. Yeah. They're like, Chad, you survived another week.
You're usually a very poor judge of character.
Yeah. But no,
that's hilarious.
I'm going to give you several dates to choose from, and tomorrow or the next day, and we're going to set something up, that's obviously convenient for you. But as we close tonight, I just want to close with a couple of things. First of all, I think it's very obvious, it's painfully obvious that you are very passionate about what you do. And that is a huge compliment because there's not a lot of people in this world that have the passion that you do for what you do, especially on the population that you treat. So God bless you for doing that. And I appreciate everything that you do for our elderly population. Secondly, I picked up so many pearls on, let's micromanage. I picked up pearls on SDF. I picked up pearls on Nystatin. I picked up pearls on checking for dentures. You
learned about a new product, Curodont, that none of us
know about. Right?
Yeah. Curodont. Yeah. So, I just want to thank you for your time. I want to thank you for your passion to our profession. And I definitely want to get you back again if you'd be willing to do so. So thank you very much.
Absolutely. Whatever I can do to help. I appreciate you. All of you. Thank you.
Well, we appreciate it. And you'll get a copy of this in the next few days. But thank you so much for your time. And go home and get something to eat. Get
Safe
some rest.
Travels.
And
thank you. Traffic should have died down by now. So it's all good. I appreciate you.
Good night.
Good night.
Take care. Good night, everyone.
Good night.
And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.